Stage A Heart Failure by David Garrison, Sarah Hassan, Rebecca Hornung, and Carol Carucci. Pathophysiology of heart failure. Heart failure occurs when the heart, whether by structural or functional abnormality, is unable to provide a cardiac output that adequately meets oxygen demands for metabolism. In 2/3 of heart failure cases, coronary artery disease has caused myocardial ischemia, which contributes to left ventricular dysfunction. As the left ventricle is injured, myocardial cells are replaced with abnormal cells, including connective tissue cells that do not have the same level of contractility. This process eventually results in dilated, hypertrophied, and spherical left ventricle that is much less effective at providing adequate cardiac output. In stage A heart failure, however, the patient is at risk for heart failure but has not yet incurred structural heart defects or other symptoms of heart failure. Risk factors for stage A heart failure include hypertension, atherosclerotic disease, diabetes, obesity, metabolic syndrome, use of cardiotoxins, or a family history of cardiomyopathy. In this stage, the patient is not fatigued by normal physical activity, but may have asymptomatic structural defect to the left ventricle. Rational drug choice. Contrary to ML's expectations, digoxin is not recommended at this stage of heart failure. Goals of therapy at this stage include a heart-healthy lifestyle for the purpose of preventing vascular or coronary disease and the prevention of structural left ventricular abnormalities. Drug recommendations revolve around decreasing the demands on the heart by controlling blood pressure and lipid disorders. Angiotensin converting enzyme inhibitors, or ACE inhibitors, or angiotensin II receptor blockers, or ARBs, are recommended for patients with atherosclerotic vascular disease, diabetes, or hypertension, with complementary statins prescribed as appropriate. Beta blockers can also be prescribed for patients with heart failure. A 6.25 milligram dose of captopril 3 times daily could be utilized as a short-acting ACE inhibitor. Digoxin. The GI tract is the most common site of adverse drug reactions of digoxin. Adverse drug reactions include anorexia, nausea, vomiting, and diarrhea. Gynecomastia is another possible adverse reaction, though rare. Central nervous system-based adverse reactions include fatigue, disorientation, hallucinations, and visual disturbances, including yellow vision and green halos around lights. Though the presence of halos is considered a sign of digoxin toxicity, they rarely occur. ML remembers halos as a classic but uncommon side effect of digoxin. The appearance of yellow halos around lights is also called xanthopsia, while altered color vision is called chromatopsia. Digoxin toxicity is usually associated with levels greater than 2 nanograms per milliliter, though symptoms may occur earlier. Signs and symptoms of toxicity may include anorexia, nausea, vomiting, visual changes, and arrhythmias. Patients at increased risk of digoxin toxicity usually have low body weight, advanced age, renal impairment, hypokalemia, hypercalcemia, or hypomagnesemia. Gender considerations. In general, gender-related differences exist in the pharmacokinetics of drugs due to differences in body composition, binding of plasma protein, metabolizing enzymes, and varying characteristics of excretion. An analysis by Sportello et al. Found no substantial gender differences in adverse reactions of ACE inhibitors and ARBs. In women of childbearing potential, ACE inhibitors and ARBs are not generally recommended due to potential teratogenic effects. Other sources state that women who are treated with guideline-recommended cardiovascular medications experience more adverse drug reactions than men. However, there is a lack of studies on gender differences. The underrepresentation of women in clinical trials and surveillance hinders identification of gender differences in the efficacy and safety of cardiovascular medications. Ultimately, there's a need for more pharmacological studies that examine gender-related differences in medications and drug therapies. Monitoring ACE inhibitor therapy. Contraindications to ACE inhibitor therapy include hypersensitivity, previous angioedema from ACE inhibitor use, concomitant use with aliskiren. Adverse effects while taking ACE inhibitors are headache, cough, diarrhea, dizziness, and fatigue. Most of these effects are temporary and mild. Monitoring labs. Prior to placing the patient on an ACE inhibitor, the patient should get baseline values of renal functioning. While on the medication, it is necessary to continue monitoring creatinine levels as they become elevated with use. The clinician should also monitor potassium levels since ACE inhibitors have the potential to cause hyperkalemia. References.